Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. And today I have a guest that the more I spoke to, the more I realized I should have had him much earlier in my podcasting career. I realized a few months ago that I've had a lot of pediatric subspecialists in my show, talking to them about pediatric emergency medicine and their field, but I've yet to have a primary care physician on the show, and primary care physicians are probably the physicians I interact with the most, since they very often call us and send patients that they're worried about, which we always appreciate, and it's very important to have communication between these two entities. So today I'm going to talk to Noah Makovsky, who is a primary care physician in Denver, Colorado. I contacted Noah a few months ago, and he was more than happy to help. So welcome, Noah. Welcome to PEM Rules. Let me just introduce you to the listeners. Noah is a primary care physician, pediatrician in Denver, Colorado. He went to medical school at the University of Colorado Medical School. He then traveled west and went to General Pediatric residency, just like me, at the Children's Hospital of LA. In 2002, following residency, he went back to Denver to start his career as a private pediatrician or primary care pediatrician in a private practice. In 2007, Noah and a medical school friend opened Colorado Kids, which is pediatric primary care, which has now 2 locations and 15 pediatric providers. Noah is also very involved in the Pediatric Care Network, a clinically integrated network in collaboration with the Children's Hospital of Colorado, which I know very well because it's a very good children's hospital. Welcome to the show, Noah. How are you?
I'm doing great. Thank you very much for the introduction, and it is great to be here. Appreciate it.
Likewise, thank you. And let me just say, I met Noah 6 months ago, something like that. And we obviously spoke about work, and I figured this will be great because I don't even know how I've had so many guests in my show. None of them is a primary care physician. And primary care physicians are people that I interact with all the time. And again, when Noah and I met, I thought it would be a great person to interview. And let's just say that Noah and I know some people in common. Would that be a fair statement?
I think that is a very fair statement.
Fair statement.
Thank you.
Very good. All right. So, Noah, what I'd like to do, I imagine that like many primary care physicians, every once in a while, you see a kid in your office that you think might just be a little too sick to be in the primary care office or in the clinic and needs to go to the pediatric emergency department. My first question to you is one that I ask all my guests. What is your ideal PEM doctor? One who does what?
Great question, and I appreciate you asking. I would say my ideal PEM doctor is one who truly listens to my patient presentation when I'm speaking to them, offers potential clinical suggestions that may help me deal with the patient if they're still in my office. And if indeed it is deemed that the patient requires a higher level of care, courteously accepts my patient and treats him or her as an extension of my office. That is recognizing that the patient will return to my office for follow-up and longer-term care following their visit to the emergency department.
Very good. I agree with all the above. And, I really respect it when primary care's physician call me before they send the kid because it always leads to better communication. I know that sometimes they're busy and it doesn't work, which is fine. But I often get calls from primary care who are about to send me a patient to the pediatric emergency department. And I have a little rule that I always accept gladly 100% of the patients they sent. It doesn't matter what it is. I just ask for 2 things, hopefully before the patient leaves the clinic. I always ask for the last set of vital signs. And if anything looks a little bit suspicious to me or terribly wrong, I just ask that they send the child by ambulance. My experience, at least here in Florida with EMS, is that they do a great job, get an IV, give oxygen if the kid needs anything like that. The second thing, I ask the primary care physician not to tell the parents what will actually happen in the emergency department, but rather build me up for success by saying something like, Mom and Dad, I'm a bit worried about your little son, your little daughter. I'm a little worried they may have appendicitis. I'm sending you to the pediatric emergency department. And over there's a doctor, there's a specialist. He's going to take care of you. I'm going to relate my concerns to him. or her, but they're gonna take care of it from this point on. Do you agree with those 2 points? What else do you think the PCP and the PEM doctors should discuss in those situations?
Great question, and I do appreciate that. I do agree generally with those two requirements from PCPs prior to PCP sending the patient to the ED. I think my only comment would be that often the patient or the parents are looking to better understand what may be happening when they eventually make it to the emergency department. And they often will ask their PCP due to the trusting relationship that they've formed over many, many years. So I agreed it is never a good idea for me to tell parents exactly what to expect. But sometimes having some idea before going into the unknown and scary environment of the ED can be helpful. That said, I always add the caveat that ultimately the emergency room specialists will determine what care will be offered based on their expertise. And I trust the emergency room physicians. And that's why I'm sending their child to that specific emergency department. Something else that's been on my mind is the way that PCPs and PEM docs view their pediatric patients and how each can learn from each other. Since I see them in my office, you see them in your emergency department, but there is some divide that occurs there. So just as an example, and ironically, while I was just in synagogue recently, I had a case in point of how much I respect I have for PEM docs and how I wish they could spend some time with PCPs reviewing some basic medical emergencies that may occur in or out of the office. Because I feel like once a physician, always a physician. So anyone who's witnessing an emergency assumes you as the physician will know exactly what to do. So while standing in synagogue just the other day, a 7-year-old boy actually collapsed right in front of me. And I know most of the kids in synagogue and actually take care of many of them. But I didn't recognize this kid. So I had no idea if he had any medical problems that would have been responsible for his collapse. So without having any equipment, all I could use was my clinical judgment. And obviously he was breathing, he had a pulse, but he was pale as a ghost. So with some relatively simple Trendelenburg positioning and some cold water on his forehead, he was quickly revived. And it turns out after questioning his mother for a little bit, they came from sea level. They'd just gotten to Denver. He likely did not acclimate to the Denver altitude, and certainly he didn't drink enough. So we decided to hydrate him up and say, you can go home, because he had quite a walk home once he actually voided. And the experience, though, made me feel as if I felt somewhat prepared, but nervous at the same time, even though this ended up being a relatively simple case. But it did make me feel that way, and I wish that we had more connections with the PEM docs to make us feel more confident as primary care physicians in those situations.
Very good. So my answer to that will be number one, great job. I probably would have done exactly the same. I got to say, Noah, you're very, very comprehensive. I think of tachycardia as a sign of dehydration. And once the kid is not tachycardic, I get them out of the ER. You waited for the kid to void because you're that comprehensive. So that's great. And I love how you guys have a phrase for people who came from out of Denver, came from sea level. That's hilarious. But yeah, that probably contributed to his presentation. I got to say, this is also a very good idea for future episode. Maybe we can discuss things that you guys as primary care would like to know more about and how us PEM doctors can provide that education.
I think that I know I would appreciate that. And I imagine many of my primary care colleagues would as well. It just reminds me of the few times I've been traveling on a plane and the request came over the loudspeaker for a doctor. And I was either the only doctor on the plane or apparently the only doctor willing to come forward. And generally speaking, most of the people on planes are not little people. They are oftentimes older people that seem to be having problems. And the bottom line is it can be terrifying. Especially for somebody like me who's in private practice as a pediatrician. We deal with a lot of acute care, but we rarely deal with true emergencies in our office. And the further I get away from residency, the less prepared I may feel to deal with these situations. So I think it would be incredible if there was a way to connect up with the PEM docs teaching and reviewing with somebody like me and my colleagues, at least their top maybe 5 to 10 emergencies that may occur in or out of the office setting to help us know how to deal with these situations. So if we can make that happen, I think everybody wins.
No, I think that's a great idea. You just inspired me again, like I said, for the content for future episodes, and I always look for content. So stay tuned. I think that can be a great idea.
Sounds good. But I'll flip it around for just a second here, because I do think there are some things that the general pediatricians could provide for the PEM docs as well. Likely, I'm sure you see many visits to the ED that may be questionable emergencies, yet the parents are beyond stressed and they need reassurance more than anything to help them move on to another day. Some PEM docs are really excellent at doing this, but others may not feel adequately trained to do so, or do not feel it's their place. But I will tell you, as a PCP, there's no question we appreciate the follow-up visit the next day after the emergency department visit, where the parents have already stepped away from the ledge because a PEM doc spent a few extra minutes with the family explaining the situation and reassuring the parents. Examples like the one we just mentioned a moment ago, of syncope or febrile seizure, a newborn who's irritable or has some issues like that, and even sometimes some of the mental health challenges that we're now dealing with. PCPs greatly appreciate the PEM docs who present their position also to the patient care as that of a collaboration with the PCP. I've had some situations, unfortunately, where it may occur that a family will return to our office following an ED visit and challenge our clinical judgment, not because they have any medical background, but because a PEM staff member intimated that we didn't exactly fully understand the condition being treated. Our approach was potentially incorrect. Obviously, PEM docs are not there to just blindly protect the PCP, but knowing how different the outpatient world is from the ED, most reasonable providers should understand that most PCPs do all they can for their patients with the tools at their disposal in the outpatient setting. And these tools are very different than those available to you in the emergency department. So the key is just to always remember that it's a continuum of care. And ultimately, we are all here to help that same patient.
Yeah, those are really, really good points. And again, the more I listen to you, the more I realize I should have had you earlier in my podcast career. But those are really good points. And just like you said, that the further away you're removed from residency, the less equipped you are with dealing with emergency. The more I am removed from residency, the less I feel equipped to deal with the primary care presentations like that I see in the ER, which I see plenty. And I got to say, I do love it. It's part of what I do. I accept it. But those are really good points that I'd like my listeners to listen to and hear. And I think it's really good points for any ER doctor, whether it's PEM doctor or not, because they all see kids, to be aware of. One more question I had, Noah, and again, I'd like to take advantage of the fact that we're having this conversation, because one of the primary care-like presentations that I see in the emergency department all the time is the spitting newborn. Parents come to the ER since their newborn baby is spitting up a lot. To them, it looks very excessive, very concerning. Obviously, as a PEM doctor, I always ask the questions about pyloric stenosis and stuff like that. But over the years, when I realized this is more like a primary care issue, over the years, I developed my approach to the spitting up newborn. Obviously, it's the PEM approach, but I would love to know what you think and what else I can tell those parents. So, in my mind, the child is free to spit up as much as they want, as long as, number one, the white rule is not violated. So I tell the parents, whatever your baby spits up has to be white, beige, color of the formula, color of the breast milk. That's number one. Number two, the baby is growing and gaining weight. Goes back to one of my rules that I talk about with the residents. The single most important indicator that a baby is healthy is growth. And number three, I ask that there's no blood in the stool. And if so, obviously, I speak to parents briefly about milk protein allergy, etc. So that's kind of like my approach to the spitting up newborn. Now, if none of those is true, I tell the parents that whatever the formula their baby is taking, that's the right formula. I see no concerns and no reasons to intervene. As far as I know, with the exception of the hydrolyzed formula, which to my understanding is Nutramigen and Elementum, all formulas are milk-based, They all have 20 calories per ounce and are really, really similar. I'm unaware of significant differences between gentle ease and super ease and all those. Am I wrong, Noah? I'd love to know your approach to that situation and what else can you teach us about that?
Great. So I would say in general, my approach to the spitting up newborn is really similar to yours. I typically ask 4 questions, and some of them overlap certainly with what you just brought up. One is the baby growing? Now, in my practice, I often have the advantage of a well plotted out growth chart to easily answer that question. So that typically doesn't take very long. Number 2, similar to what you said, do the parents recognize what the baby is spitting up? In other words, it should look like breast milk or formula, very similar to ensuring that the white rule is not violated. I will also ask, is the baby in pain with spitting up? Acid reflux is a relatively common entity that we see in primary care, and parents often come in presuming their child will receive a medicine for spitting up. But I always explain the meds that we use are anti-reflux medicines. They're not anti-spit-up medicines. So we typically only go down the road of discussing meds if the baby appears very uncomfortable just before, during, or right after spitting up. And then the last thing that I just directly ask them is the spit up or vomit projectile, which I usually explain is shooting out a good 2-3 feet or more straight out of the baby's mouth. Not what appears to be a large waterfall, because I hear that quite a bit in my practice. And obviously thinking about pyloric stenosis or other anatomic or obstructive issues that may need to be investigated. And then depends on the spitting up itself. I may not immediately talk about blood in the stool, although it's not uncommon that something like that will come up, particularly with these families that know me very well. If they've seen anything, they immediately will either show me a lovely picture or even better, bring in a diaper so I can really see what they're talking about. So I think it's definitely worth talking about here for just a moment. If the blood is present in the stool, it definitely takes us down the path of either a milk protein intolerance or possibly a milk allergy. At that point, a change to mom's diet or a change in formula is warranted. If there's no blood present, I agree that changing mom's diet or the formula is unlikely to affect a happy spitter. But that said, besides for reflux, an unhappy spitter may benefit from mom removing dairy or soy from her diet or changing the formula to a partially hydrolyzed formula. You mentioned one like Gentle Ease. And although we got to be a little careful because this can be a slippery slope, since we certainly try to avoid making too many changes to mom's diet and or to the formula, because this can be very stressful for moms, for parents, and it certainly can be very expensive, as I have seen many families come in and give me a litany list of all the formulas that they have tried. And I know that these are not inexpensive choices for them to make.
Very, very good. Again, I love that you just gave me a few things to think about. So I guess I never really think to ask the parents if the baby seems to be in pain or not. That's a great point. And I love the description of the waterfall. That will definitely make me reassured that I don't have to get pyloric ultrasound today. That's great. No, those are really, again, really, really great points. Thank you so much for coming on the show. And again, I think we got an idea for a future episode that you're more than welcome to collaborate again. We'll discuss a few topics that maybe primary care physicians want to get more comfortable with, and PEM doctors can help. Again, thank you very, very much.
Thanks for the opportunity. Looking forward to bridging the gap here even more so between primary care pediatrics and pediatric emergency department folks. So thank you very, very much. Appreciate it.
So Noah, as usual, I'd like to honor my guest with an outro of their choice. You indicated that you would like something by Elton John or Billy Joel, both of which are great pianists, and my piano skills are mediocre at best. I am aware that you like The Police and you like Sting, so here's my version for Message in the Bottle. Not an easy one. That's the best I can do. I hope you like it, and thanks again.
Thank you very, very much. Appreciate it.